respected chairpersons, faculty, and delegates. First of all, thank you very much, TCT India and Dr. A. Srinivas Kumar sir team for giving me this opportunity to share something about neurointerventions. Uh, so I am a neurosurgeon with interest in vascular neurosurgery. So apart from open neurovascular, microvascular procedures, I trained in doing endovascular procedures as well. And what I'm sharing you is my experience since the onset of COVID. We have done some difficult neuro interventions. So generally, when we talk about interventions, we talk about the arterial pathways, but I'll start with the venous route here. And all of us know that since 2015, mechanical thrombectomy has come in a big way in treating acute ischemic stroke. The first case I'm showing is that of a 30-year-old male with who's a diabetic and hypertensive, and he presented with 2 weeks history of headache, and he was showing at several centers, and initially a CT scan was done, and that did not show any significant abnormalities. So he was given medications and then sent back, and his headache did not subside. And over a period of time, he became drowsy, and then one fine day he had sudden onset slurring of speech, right hemiparesis, and seizures, and he was taken to another center in altered sensorium, and he also developed status epilepticus there. He was intubated and shifted to our center. So given this background history, there was a strong suspicion of cortical sinus venous thrombosis, and then the MRI was done under anesthesia, and which showed a definite sinus venous thrombosis. I don't have the MR images, but this was the CT image, which showed that there was a bleed in the left parietal region. And with this background, because of the presence of bleed, there was a hesitancy about giving high dose heparin, and the neurologist had requested if something else, if we can do manual aspiration of the clot from the sinuses. This is described very well, that if patient doesn't respond to heparin therapy, or patient comes in a state where all the sinuses are blocked. For example, if you see this angiogram, this is what was seen on the MR. That's why we had taken up the intervention as well. This is the actual, on the right side, we have the normal angiogram where you can see the superior sagittal sinus, the other deep superficial venous system, deep venous system, and then the transverse sigmoid sinus draining into the jugular vein. Whereas here you see that there's a gross paucity of veins. You can appreciate the cortical veins, but the whole brain is actually draining through only one sphenoparietal sinus into the jugular bulb. The deep venous system is also not seen. So this is a condition which probably cannot be managed just with heparin. So we went ahead, after counseling the patient, we took the transjugular approach using a 7 French sheath. We have an A68 aspiration catheter, and I will describe what has been done. So a transjugular puncture was done, and with a sheath in place over here, we went into the transverse sigmoid junction. It was a blind approach. That catheter went on freely, except for the valve at the IJV level. And then when we injected, we found that there is no anterograde flow into this particular pathway. There's only a retrograde flow, anterograde flow up to the contralateral transverse sigmoid junction, and nothing beyond it. And even in this flow, you can see that there's so much of opacities, which indicate that there is a lot of thrombus load here. Then I took this catheter up into the superior sagittal sinus, which you can see in the lateral view, and I went all the way anterior third of the superior sagittal sinus. When I injected there is no flow coming down the superior sagittal sinus down into the transverse sigmoid area, and all the cortical veins which are opacifying in the frontal area are actually draining through the sphenoparietal sinus. So this is the X-ray image showing the sheath and the aspiration catheter over here. So after aspiration, I started aspirating from the anterior part. Around 3 or 4 attempts later, I got this much of clot from the venous system. Despite so much of clot being aspirated, the venous system was marginally better, in the sense that apart from this draining vein, now we have another draining vein over here. So this is draining into the jugular bulb again. So since I was not satisfied with the amount of flow, and still other thing to note is the deep venous system is still not open, that the straight sinus is not open. So then I took something like a Fogarty maneuver. I took a large balloon, and then I tried to partially inflate it and then try to remove the withdraw the balloon through the transverse sigmoid sinus and through the straight sinus. Even in this maneuver, I was not able to completely achieve this opening of this vessel. However, this particular vein, which was not seen earlier, got open. So now there are two drainage pathways through the through the superficial system. One is the sphenoparietal sinus. The other one is this superficial cortical vein, which probably the anastomotic vein of Trollard, which is seen, which is draining the vein. But the most important thing, the deep venous system, which actually drains the basal ganglia, the brainstem areas, are still not seen. So what I did was I placed a catheter through. I took a roadmap to see where exactly was the approximate location of the straight sinus. And the petrosal sinus. So through the petrosal sinus and I tried to cannulate and then reach the straight sinus. So this is the microcatheter injection, which was left in the straight sinus. When I injected, the straight sinus is outlined here, and you can see that there is a lot of thrombus load over here. So what we did is on-site chemical thrombolysis. We left a continuous infusion of tissue plasminogen activator through this microcatheter and continued for the next 24 to 48 hours. And then after that, we removed the catheter after 48 hours, and then we did an MR. And MR showed, before we removed the catheter, we actually did the MR. MR showed that there's an infarct in the medial part of the occipital lobe and in the thalamus over here, and a little bit on the left hemisphere, posterior frontal region. There was also an MR venogram, but which showed that the MR venogram is not visible, which showed that the deep venous system had opened up. The superficial system had not opened up completely, but the anterior 2/3 had opened up. And this patient was gradually undergone tracheostomy. He had a 1-month stay in the hospital, but nevertheless, at the end of 3 months, his seizures came down and he had minimal motor deficit. He reached a state where he was independent he was able to do his activities independently, and there was no cognitive dysfunction. Let me just see if this venogram, yeah, this is the venogram. As you can see that the anterior 2/3 is open and the drainage is through this superficial vein, and there's a deep venous system is now seen quite clearly. Although one side transverse sigmoid sinus is open, the other side has not opened up, but this is sufficient. This was probably sufficient for his brain to function adequately. So the second case is, now I'll go to the posterior circulation, the arterial route. 67-year-old male who was evaluated for episodic dizziness while getting up since 1 month duration. There were no neurological deficit which could localize clinically to any particular area. So he had undergone a CT scan which showed that there was this lesion in the which was distorting the pons in the posterior hemisphere. There was calcifications in the wall. So obviously the two differential diagnoses were either a tumor or a vascular pathology, and he underwent a CT angiogram which showed that there was a giant fusiform aneurysm. Fusiform aneurysms are pretty common in this particular location. Fusiform aneurysm in the vertebrobasilar junction. Actually, it is in the vertebral junction, and there's only a small area distal to the aneurysm, which then joins to form the basilar artery. As you see, the origin of vertebral is tortuous on one side, whereas the other side is fairly straightforward, except for the area where it enters the dural sac, where we have over the C1 arch, where we have the loops. So because this was a symptomatic aneurysm and we need to treat it, surgically, it is a very complicated procedure. We need to do a occipital artery pica bypass, and then we need to take out this aneurysm. But with the advent of newer flow diverters and braided stents, it was a simpler option to go forward. However, though it was anatomically challenging, this is the vertebral injection, which shows that there is all the contrast is pooling in the aneurysm. There is no flow beyond the aneurysm into the basilar artery. So I had to do a puncture on the other side, inject the contralateral vertebral artery, and retrogradely the aneurysm was filling. So now I have, normally the basilar artery should be somewhat straight like this. In his case, it has taken it's a dolichoectatic course where it had taken a very a loop-like thing. Also, we can see that the lumen size is not same. There's a proximal and distal variation. So I had technical challenges in negotiating the guiding the microcatheter across into the aneurysm. My initial plan was to place the stent in the lower third because of the mid-pontine perforators which occur in the middle one third of the basilar. But as I was placing the stent, it was slipping down and coming. So I had to take a chance and go ahead. And as I was resheathing the thing, there was a loop which was formed in the aneurysm. And because of that pull and push maneuvers, there was a transient bradycardia. We had to halt the procedure for a few minutes. And then once the bradycardia improved, I went across. Then I started deploying the stent from the middle one third. And this time, one stent I deployed till here, and then it did not stay here. So it again went back into the aneurysm. So I was prepared for 2 stents considering the anatomy here. So I went telescopically again into the first stent. And again, as I was going inside, it again formed a loop there. And then the stent there was a foreshortening here. But despite that, we could go across and then deploy the second stent. And this is deployment of the second stent, and the second stent was deployed here. So 2 telescopic braided stents were placed, and the patient was discharged in 2 days' time. And at the end of, towards the follow-up period, we did a CT. This is the stent over here. We did a CT angio at the end of 3 months. This is the initial image, the time of completion of procedure, showing that there's a stasis in the aneurysm. And now we can see that the flow is seen distal to the aneurysm also. And this is the follow-up CT angio, which shows that the stent is seen over here, the braid telescoping stents, and the size of the aneurysm has come down significantly. So over a period of time, I'm sure that another 3 to 6 months time, this will disappear completely. This is the other view showing that there's only a small residual sac which is seen over here. The last case is a 54-year-old male coming to the anterior circulation who was evaluated for a retroorbital pain. And this was what they found on the CT brain and MRI was done. And with the suspicion of an aneurysm, they found this giant aneurysm, which was located in the supracranial ICA just behind the eye. And as you can see, again, there's so much of tortuosity in the cavernous bend. The size of the proximal and distal landing zones is different. And there's so much of flow here. And my challenges here was crossing this bend and going into the outflow tract. So we did the measurements and then kept a long sheath over here, took a guiding up to this particular bend. And as I was crossing to the outflow tract, the microcatheter took a double loop. But then when we withdraw, it should straighten up. But as I was withdrawing, I found that the whole microcatheter was slipping and coming out. So I needed some kind of a grip in the outflow tract. So I had to use a stent retriever, which is generally used to remove the clot. I deployed the stent retriever. The markers are seen over here and here. And this acted something like a grip. And then after I straightened the microcatheter, I gently removed this solitaire or the stent retriever. So now we can see that the microcatheter is in place to deploy the stent.
Dr. Rajesh, yes, please just complete.
Yes,
Conclude. You have exceeded your time, please.
So finally, we placed a stent and then 2 coils. And then this is the final outcome, that there is a stasis there. And this is the final outcome there. We are planning to do a control angio after a month. So we have done, like I said, ischemic stroke, arterial venous procedures, aneurysms, symptomatic bad carotid stenosis like this, dural AV malformation and dural AV fistulas as well. So thank you for your kind attention and thank you for time.